Picture a tiny pair of newborn feet. Perfect in every way, right? But sometimes those little feet have a twist. Literally. We're diving deep into Talipes Equinovarus today,
Right.
or as it's, more commonly known, clubfoot.
And think of this as your sort of audio cheat sheet for Clubfoot. Our mission here is to give you a really clear, concise overview.
Exactly.
Hitting all the key areas, offering some memory aids maybe, so this stuff really sticks when you need it most.
Right. So let's start simple. What actually is clubfoot?
Well, fundamentally, it's a condition babies are born with, a congenital condition,
Okay.
where their foot and ankle are twisted inwards and downwards. It makes it difficult, sometimes impossible, to place the foot flat on the ground.
Like trying to stand on the outer edge?
Kind of, yeah. And it's usually something doctors spot, right away at birth.
Okay. And I gather there are different types.
Broadly speaking, yes. You've got positional talipes. That's often more flexible, maybe just from how the baby was positioned in the womb. It's often correctable with gentle manipulation.
Simpler to fix, potentially.
Potentially, yes. Then there's congenital talipes. This is a more fixed structural issue. It can be idiopathic, meaning we don't know the exact cause, or sometimes it's linked to other underlying conditions.
Let it. So in this deep dive, we're aiming to cover, well, pretty much everything.
The full picture.
Definition, the causes or etiology, risk factors, what's actually happening physiologically, pathophysiology.
What else? It could be the differentials, how common it is, epidemiology, both UK and global.
What it looks like clinically, how it's investigated, managed, the prognosis, and any potential complications down the line.
Sounds like a plan. Let's dive in.
Okay, definition first. Let's really nail this down.
Right. So remember those key terms. Varuses means inward twisting, and equinuses means downward pointing, like a horse's hoof almost.
Okay. Varus inward, equinus downward.
Exactly. So the foot's turned in and pointing down. And it's important to remember this isn't just, a temporary position. It's a permanent alteration of the foot's structure.
And you mentioned something about the arch.
Yes, often there's a characteristically high medial longitudinal arch. That's the inner arch of the foot. We call that cavus. It can look quite scooped out.
Okay. And revisiting those two types again quickly. Positional versus congenital.
Right. So positional, think flexible, possibly related to uterine positioning, maybe less amniotic fluid, that kind of thing. Gentle correction is often possible.
And congenital.
That's more fixed, more rigid, and this is the type that can be associated with other conditions.
Like what sort of conditions?
Things like spina bifida, cerebral palsy, or a condition called arthrogryposis, which involves multiple joint contractures.
Right, so more systemic issues sometimes.
Sometimes. Whereas positional talipes, as we said, might be linked more to things affecting the space in the womb, like oligohydramnios, too little fluid, or even polyhydramnios, too much fluid, or maybe uterine anomalies.
Okay, that distinction is helpful. Now, how do clinicians assess severity? Is there a standard way?
There is, yeah. The Pirani scoring system is widely used. It's a clinical score, looking at 6 specific anatomical features of the foot.
6 features. What does it tell you?
It gives you 2 scores, basically. One for the hindfoot contracture score, or HCFS, and one for the midfoot contracture score, MFCS. A higher score initially might suggest more casts will be needed during treatment.
Makes sense.
And it might also predict a slightly higher risk of relapse later on during the bracing phase, but it's not absolute.
So a high score means more treatment, potentially.
Generally, yes. But interestingly, even a low initial score doesn't completely rule out the need for a small procedure later, like an Achilles tenotomy.
Okay, we'll come back to treatments.
Yeah.
Let's shift to etiology. Why does clubfoot happen? What's the cause?
Well, the honest answer is the exact cause is still largely unknown. It's thought to be multifactorial,
Right.
meaning it's likely a combination of genetic predisposition and environmental factors interacting during pregnancy.
So genetics plays a role.
Yeah.
Family history matters.
Definitely. Family history is a known risk factor. If a parent or sibling had clubfoot, the risk is higher.
And environmental, you mentioned uterine position.
Yes. Factors like how the baby is positioned in the uterus, the amount of amniotic fluid, things like that might play a part, particularly in the positional type.
Is there a leading theory that combines these?
There's something often referred to as the consensus theory. It basically suggests it's a mix of, well, several things. Neuromuscular factors, subtle anatomical differences, a polygenic genetic basis, meaning multiple genes involved, not just one.
Okay.
And potentially some element of arrested fetal development, where the foot's development pauses or goes slightly off track at a critical stage.
Right. And to recap those specific associations again, for positional and congenital.
Sure. For positional, think things that restrict space. Oligohydramnios, low fluid, unusual uterine shape, multiple pregnancies like twins or triplets.
Oh, no.
For the congenital type, in about 20% of cases, it's associated with other conditions. We mentioned arthrogryposis, also things like myotonic dystrophy, and myelomeningocele, a severe form of spina bifida.
So sometimes it's a clue to look for other things.
It can be, yes.
Okay, let's talk risk factors specifically. Who is more likely to be affected?
Well, we've touched on some. Family history is a big one.
Right.
Being male slightly increases the risk. It's a bit more common in boys. And then there are maternal factors during pregnancy, like smoking or a certain drug use, which have been linked.
And those associated conditions we keep mentioning, spina bifida, etc., are they also risk factors?
They are considered strong associations, yeah. So conditions like spina bifida, cerebral palsy, trisomy 18, that's Edwards syndrome, oligohydramnios, arthrogryposis, these all increase the likelihood of clubfoot being present.
Understood. So moving on to the pathophysiology, what's actually going wrong with the development?
Fundamentally, it boils down to abnormal development and positioning of the foot and ankle structures while the baby is growing in the womb.
So bones, muscles, tendons.
Exactly. The muscles, the tendons, those connective tissues linking muscle to bone, and the ligaments that stabilize the joints, they can all be affected. They might be shortened or thickened or just positioned incorrectly.
And that pulls the foot into the characteristic shape.
Precisely. That abnormal pull from the soft tissues results in that fixed, twisted position of the foot and ankle.
But the exact trigger, the why, behind that abnormal development is still a bit murky.
Yeah, the precise molecular and cellular mechanisms that disrupt the normal developmental pathways aren't fully understood yet. Research is ongoing.
Okay, so if a baby is born with a foot that looks twisted, how do doctors make sure it is clubfoot and not something else? What are the differential diagnoses?
That's a really important clinical step. You need to differentiate it from a few other conditions.
Such as?
Well, one is metatarsus adductus. Here, only the front part of the foot, the forefoot, turns inwards. The heel and ankle are usually okay, and the foot is generally quite flexible.
So different from the fixed hindfoot issue in clubfoot.
Exactly. Another one is congenital vertical talus. This is different again. The talus bone in the ankle is sort of pointing downwards, creating a rigid flat foot, often called a rocker bottom foot.
Rocker bottom, okay.
Yes, it looks quite distinct. And then, of course, there are other rarer congenital foot abnormalities. But the key thing for clubfoot is that combination of hindfoot equinus and varus plus forefoot adduction and supination, and usually that rigidity.
Got it. Let's talk numbers now, epidemiology. How common is this, say, in the UK first?
In the UK, the prevalence is estimated to be around 1 to 2 cases per 1,000 live births.
Okay, so not incredibly rare.
No, it's one of the more common congenital musculoskeletal anomalies. And as we said, slightly more common in males. There might be some variation among different populations too, but generally that 1-2 per 1,000 figure holds.
And globally, what does the picture look like worldwide?
Pretty similar incidence, actually, around 1 in 1,000 births globally.
Wow, okay.
And interestingly, in about 50% of cases, half the time it affects both feet. That's bilateral clubfoot.
Right.
And that male predominance we mentioned. Also seen globally, about twice as common in boys. The sheer number is significant, maybe 150,000 to 200,000 new cases worldwide each year.
That's a huge number.
It is. And a major challenge is that the vast majority of these cases occur in low and middle income countries.
Where access to treatment might be limited.
Exactly. Limited access to effective treatment, like the Ponseti method, means many children, unfortunately, end up with severe lifelong disability. It's a significant global health issue.
Definitely puts it in perspective.
Yeah.
So, clinically, what are we looking for at birth? Describe the typical appearance again.
Okay, the absolute hallmark is that foot twisted inwards varus and downwards equinus. It's usually immediately recognizable. The severity can vary, though, from relatively mild to quite severe and rigid.
And you might see other things too.
Yes, associated abnormalities in the muscles and soft tissues. You're looking for that rigid hindfoot equinovarus, the heel pulled up and in. The forefoot is adducted, pulled inwards, and supinated, so the sole faces inwards or even slightly upwards. You often see that high arch, the cavus. The heel itself might look small. The fibula, that bone on the outside of the lower leg, might seem more prominent. And very often, particularly if it's unilateral, the calf muscle on the affected side is smaller, and the whole foot can be smaller, too.
That difference in calf size is quite common then.
Yes, it's a very typical finding.
And what about later in life? If someone had clubfoot treated as a child, are there any lingering signs?
Even with really successful treatment, some subtle differences might remain. You might still see slight forefoot adduction, maybe some residual tightness in the Achilles tendon, and that size difference, the affected foot, often stays a bit smaller throughout life.
Okay, so diagnosis is mainly clinical, based on looking at the foot.
Primarily, yes. That visual inspection at birth is usually enough for the diagnosis.
But you mentioned imaging earlier. When does that come in?
Imaging isn't usually needed for the initial diagnosis, but it's very useful for assessing the severity more objectively and, crucially, for monitoring progress during treatment. Seeing how the bones are responding to the casting or other interventions.
What kind of imaging?
Standard X-rays are the mainstay, usually an antero-posterior AP view front to back and a lateral view from the side. These help visualize the alignment of the bones, particularly the talus and calcaneus in the hindfoot.
Right.
Sometimes ultrasound might be used, particularly maybe during the manipulation phase of treatment, as it can give real-time feedback on correction without radiation. But X-rays are more common for tracking overall progress.
Okay, let's move into management. How is clubfoot treated, focusing on the UK approach? What are the main principles?
The absolute key principle is early intervention. Treatment should ideally start within the first few weeks of life for the best outcomes.
And it's usually non-surgical first.
Almost always, yes. Non-surgical methods are the first line and highly effective, especially for idiopathic clubfoot.
So what are these non-surgical methods?
The gold standard, really worldwide now, is the Ponseti method. It's used for infants, usually up to about age 2.
How does that work?
It involves very specific, gentle manipulation and stretching of the foot to gradually correct the deformity, followed immediately by applying a long leg plaster cast from toes to groin.
Okay.
This cast holds the correction achieved. It's typically changed weekly for about 5 to 8 weeks on average, sometimes longer, with further gentle manipulation at each cast change.
Gradually correcting the position over time.
Exactly. And in a very high percentage of cases, maybe 80–90%, the final part of the Ponseti casting phase involves a small procedure called an Achilles tenotomy.
The tendon lengthening you mentioned.
Yes. It's usually done under local anesthetic to release the tight Achilles tendon, allowing the foot to dorsiflex properly to lift up. After that, there's a final cast for about 3 weeks.
And then? Is that it?
No, that's just phase 1. Phase 2 is maintenance, which is absolutely critical. After the last cast comes off, the baby wears special boots attached to a bar. It's called a foot abduction brace.
Boots and bar. How long for?
Initially, full-time, 23 hours a day for about 3 months. Then it gradually reduces to just nighttime and naps, but, and this is crucial, it needs to be worn until the child is about 4 or even 5 years old.
Wow, that's a long commitment.
It is, but it's vital to prevent relapse. Adherence to bracing is probably the biggest factor in long-term success.
Is Ponseti the only non-surgical route?
There's also the French functional method. This involves daily sessions of stretching, manipulation, and taping by a specialized physiotherapist. It requires a very significant time commitment from parents and the physio team.
More intensive.
Much more intensive in terms of daily input, yes. While it can be effective, the Ponseti method is generally favored in the UK and many other places due to its high success rates and perhaps slightly less demanding daily schedule once the casting is done.
Okay, what about surgery? When does that become an option?
Surgery isn't the primary treatment anymore for most infants with clubfoot. It's typically reserved for specific situations, like older children presenting late, or cases where the Ponseti method hasn't fully corrected the deformity, or perhaps if there's a significant relapse despite good bracing. It might also be needed for clubfoot associated with neuromuscular conditions, which can be more resistant.
And what kind of surgery are we talking about?
It varies depending on the residual deformity. It might involve release procedures where tight soft tissues, ligaments, joint capsules, tendons are surgically released or lengthened. For older children or more severe cases, bone surgery, osteotomies where bones are cut and realigned, or even joint fusions might be considered.
More invasive then?
Definitely more invasive than the Ponseti method. And there's ongoing discussion about the best surgical techniques and the optimal timing if surgery is needed. The goal is always to achieve a functional, plantigrade foot one that can be placed flat on the ground.
And after treatment, whether casting or surgery, what's the follow-up? You mentioned bracing until age 4 or 5.
Yes, that long-term bracing is key after Ponseti. Regular follow-up appointments are also essential to monitor for any signs of relapse.
How common is relapse?
Even with excellent initial correction using the Ponseti method, relapse can occur. The reported rates vary, but it might be somewhere around perhaps 10 to 15%, maybe slightly higher in some studies. Good brace compliance drastically reduces this risk.
Right, so vigilance is needed.
Absolutely. Ongoing monitoring is part of the standard care.
Okay, so let's talk prognosis. What's the general outlook for a child born with clubfoot today?
Overall, the prognosis is generally very good to excellent, particularly with that early diagnosis and consistent treatment using methods like Ponseti.
So kids can expect good function.
Yes, most children treated effectively can achieve a foot that looks normal or near normal, is functional, pain-free, and allows them to walk, run, play sports, and wear regular shoes.
That's really positive. Does it depend on severity?
To some extent, yes. The initial severity, whether it's idiopathic or associated with other conditions, and critically, how well the treatment plan, especially the bracing, is followed, these all influence the long-term outcome.
What happens if it's not treated? We touched on this, but what's the outcome?
Without treatment, the deformity inevitably worsens. The child learns to walk on the side or even the top of their foot. This leads to abnormal weight-bearing, calluses, pain, significant stiffness, shoe wear problems, and ultimately severe disability and social stigma in many cultures.
A stark contrast.
Huge contrast. Treatment is transformative.
And with the conservative treatments, Ponseti and French methods, what are the success rates like?
Really impressive. For idiopathic clubfoot, initial correction rates with the Ponseti method are consistently reported above 90%.
Wow.
Yeah. And even if a relapse does happen later, it can often be managed effectively with further Ponseti casting, perhaps another tenotomy, and restarting bracing.
And if surgery is needed, what's the prognosis then?
Surgery aims to correct fixed deformities that haven't responded to conservative measures. It can achieve correction, but it's a bigger intervention.
Downsides.
Well, surgery carries risks like any operation. It can sometimes lead to scarring, stiffness, maybe some muscle weakness. Occasionally, further surgeries might be needed down the track. And extensive surgery, especially involving bones, might potentially affect foot growth or lead to arthritis later in life, though modern techniques aim to minimize this.
So non-surgical is definitely preferred if possible.
Absolutely. The outcomes tend to be better with less stiffness and more natural foot function long-term with the Ponseti method compared to extensive surgery.
Okay. Lastly, what about complications? Are there potential issues arising either from the condition itself or the treatment?
Significant complications are relatively rare with modern treatment like the Ponseti method, but potential issues can include some residual, usually mild foot deformity, perhaps some muscle imbalance around the ankle, minor differences in gait, or, as we mentioned, the risk of relapse if bracing isn't followed.
Anything else?
Occasionally, due to altered foot mechanics, even after correction, individuals might be prone to developing calluses or areas of high pressure on the soles of their feet, but this is usually manageable with appropriate footwear or insoles. Skin issues under casts or braces can occur, but are usually preventable with good care.
Right. So overall, manageable risks with good care.
Generally, yes.
So wrapping things up, what's the main takeaway message for our listeners revising this topic?
I think the crucial point is optimism, grounded in evidence. Early diagnosis, coupled with consistent expert treatment, predominantly the Ponseti method followed by diligent bracing, offers an excellent prognosis for most children born with clubfoot.
Functional, pain-free feet are the goal, and it's achievable.
Absolutely. It's a treatable condition with fantastic long-term outcomes possible in the vast majority of cases.
Great. And of course, if any section felt particularly dense, you can always rewind and listen again to nail those details for your revision.
Definitely. And, thinking about the success of treatments like Ponseti, but also reflecting on the global epidemiology we discussed.
Right. The disparity in access.
Exactly. It really poses a thought, doesn't it? Considering that huge burden of untreated clubfoot in lower resource settings, what innovative, scalable, and sustainable solutions could we realistically implement to bridge that gap? How can effective treatment reach every child who needs it, regardless of where they're born?
That's a really important question to ponder. Food for thought indeed. And for more high-yield MSRA revision resources, do make sure you check out pastmsra.com.
And also freemsra.com for some great free materials.
Excellent resources. Well, thank you for joining us for this deep dive into Talipes Equinovarus.
Thanks for listening.